Hello, everyone, and welcome to the IOCDF Research Roundtable. I'm your co-host, Kyle King. I'm a no longer sophomore. I'm a rising junior at Yale University, studying neuroscience and also a research assistant at the Yale OCD Research Clinic. And I'm not just some teenager that started to like OCD for no particular reason. I myself have OCD, and I've been a longtime advocate to help raise awareness for the disorder. As always, I'm joined by my co-host, John. John, if you want to introduce yourself?
Sure. Thanks, Kyle. I'm John Abramowitz, and I am a professor at the University of North Carolina, and I'm fascinated by the treatment of OCD and studying and understanding all about OCD. And I'm really psyched. I got to say, we've done a bunch of these panels, sixth or seventh roundtable now, and I've been more excited about this one than, no offense to the others, but I am really excited about this one. We have some great guests on.
Yeah, the others are just awful. Gosh.
Right.
Yeah, well, today we're going to be talking about scrupulosity. And before we get there, there's some things that I have to get off my chest. There's some very deep and personal things. And those are the disclaimers. So first, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Further, the International OCD Foundation is not a crisis hotline. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. And second, for those of you who are already here, there's a chat feature. All the chats are live. So if you put something in there, all the panelists can see it, everyone else on the live stream can see it, and everyone else who watches this live stream after can see it. So please be considerate and respectful when you're using the chat feature. And if you want to test it out, I think, Jed, you're in Philadelphia right now, right?
Philly suburbs, yep.
Yeah, so I just got into an argument with my friends about Philly because I said it was a top 10 city in the country. And they all told me that I'm terribly wrong, and it's like barely top 30. And then we started talking about where would we want to go on like a summer vacation. So if you guys in the chat want to put one, where you're tuning in from, and two, one city in the world that you'd want to visit on summer vacation, let me know. But anyway, we also have two guests here who know a lot more about scrupulosity than I certainly do. John, I don't know if you consider yourself an expert on this topic.
Well, kind of, but I think these guys know more than I do.
It sounded like it when we were talking backstage. Yeah. So I'm going to go ahead and introduce them. I'll start with you, Jed. Jed Siev, I'm pronouncing that right?
Close enough.
Cool. Is an associate professor of psychology at Swarthmore College and a licensed clinical psychologist. Previously, he directed the Anxiety Treatment Center and founded the OCD and Related Disorders program at Nova Southeastern University, which is right in my backyard, after completing training at the Massachusetts General Hospital and the University of Pennsylvania. Jed's research focuses on information processing, judgment and decision-making, and metacognitive processes involved in the maintenance and reduction of OCD, hoarding, and anxiety, and he has a particular interest in unacceptable thoughts and especially scrupulosity. He is currently writing a book for Oxford University Press on how to treat scrupulosity. Jed, how you doing?
Hey, thank you so much for having me. I'm looking forward to it.
I'm going to ask you a lot of questions about the treatment of scrupulosity.
And then I'll turn them to John.
And I'm psyched for the book. That's going to be really cool. We need one of those. There's not.
And John's got a contribution in the book, I should mention as well.
So, like John,
chapter, of course. No, I'm kidding.
John's just kind of like plugging himself, but low key. Like, also, don't let me forget to plug the book at the end of the show, too, because I forgot last time we had a panelist writing a book.
That'll give me a lot of pressure to get it finished.
Good. And Katie, I'm also going to be asking you treatment questions. Our other panelist is Reverend Katie O'Dunn. She is the founder of Faith and Mental Health Integrative Services, an organization helping individuals with OCD and related disorders live into their faith traditions as they navigate evidence-based treatment. Prior to this, she spent 7 years serving as the Academy Chaplain and the Pauline and R.L. Brand Jr., 35, Chair of Religious Studies at Woodward Academy in Atlanta, Georgia. While serving in this role, she also served as a consultant on interfaith programming for schools around the country. Katie is proud to be an IOCDF lead advocate or ordained minister in the in the United Church of Christ, and an endurance athlete tackling 50 ultramarathons for OCD. She is currently pursuing her doctorate at Vanderbilt to continue her focus on faith and mental health. She graduated from Candler School of Theology at Emory and her Master's of Divinity and Certificate of Religion and Health in May 2015. Katie, I don't know where to start quite with asking you about this bio, because you clearly have a lot of experience and know a lot of stuff about this topic in particular, but how do you do an ultra marathon? I think that stands out to me the most.
Yeah, that's such a great question. Yeah, I'm still kind of figuring that out. So I've been a runner forever. I was a D1 runner in college and then got into endurance triathlon and raced actually before getting into OCD advocacy. I raced 7 half and 3 or 4 full Ironmans. And then during the pandemic, yeah, so I've been doing this for a while. And then during the pandemic, right before the pandemic really started to become more public about my OCD. I guess I didn't have that in my bio. I'm a minister. I also have OCD. I'm super public about it. But in the midst of that, I was kind of looking for a new challenge and kind of got bored with triathlon and was like, oh, I should run an ultra marathon. And I think sometimes I do things to the extreme. So it quickly switched to, why don't I do 50 in 50 states? And why don't I fundraise for OCD while I'm doing it? But those of you who know Ethan Smith and follow kind of our journey with these ultras will attest. The first one wasn't necessarily the best. I got food poisoning and I got stung in the face by a bee, and there was a whole series of things. And it was like, okay, 49 to go, but we're on track and it's fun.
You got stung in the face by a bee while running?
Mm-hmm.
I
grabbed an orange from the aid station and put it in my mouth, and there was a bee on the orange, and it like jammed me through the face. Yeah.
Yeah.
Anyway, sorry. I know that has nothing to do with Scroop, but fun stuff.
Someone said in the chat, I got bored with triathlons. Yeah, I'm never going to say that either. I ran like a mile and a half.
We don't actually talk about OCD in these roundtables. We just kind of get it around for, an hour.
Yeah, I mean, we could. Katie gave us a lot to talk about. But I guess we should talk about Scroop. So to the three of you, just generally to get us oriented, what is scrupulosity in the most general terms? Anyone?
Got it.
Reverend Katie, you want to take that one?
I was going to throw it to you for the clinical side.
Okay, I'll take the first stab at it. I think of scrupulosity as a manifestation of OCD where the core fears have something to do with religious or moral themes. And so very often it can be manifest as a type of unacceptable thought, OCD, but it doesn't have to. So people can have contamination-related OCD fears, but the contamination is maybe ritual contamination, religious contamination of some sort. There can be checking, but the checking is tied to religious or moral themes. It can be blasphemous, intrusive thoughts anytime you're in a house of worship, and that would be sort of similar to unacceptable thoughts. It could be having to be just so precise in the way you enunciate something or the way you perform or line something up, religious articles, let's say, or not necessarily, again, with religious or moral themes. So that's my short version on scrupulosity.
Mm-hmm.
Yeah, and that's, I mean, there's not really anything I would add to that, just for folks listening who might not be as familiar with it. Just also emphasizing that, again, like Judd said, that this is an OCD issue as opposed to a faith issue, and particularly for folks in faith communities. Sometimes this can be really confusing because on the outside, it might look like someone is doing something to be quote unquote faithful or to live into their faith in a way that's meaningful. But it's really not. They're in this process almost worshiping the OCD as opposed to worshiping God. And they aren't doing things that are meaningful to them or to their faith, but rather being pulled by the OCD.
Actually, I'm just going to tack on one last thing that Reverend Katie reminded me of, which is that, so I said religious or moral. So you can have secular forms of scrupulosity. Sometimes when somebody is not religious and they have scrupulosity, it still is pretty religious scrupulosity. Maybe somebody who was raised in a certain faith tradition or something like that, and they may have rejected it, but they still have concerns, residual, obsessional sort of concerns. But sometimes it could be just completely secular. So for example, somebody was telling me about the obsessions that she has when she hears about or reads about something awful that's happened, which is all the time nowadays, it seems. And she'll start to obsess about whether she felt it enough, and did she really feel enough empathy, and what might that mean about her as a person? If not, is she really a bad, evil, callous kind of person? And sort of starts analyzing the quality of who she is from a moral standpoint. So that might be an example of secular moral scrupulosity, where the obsessional themes are about sort of good, bad, am I evil, am I callous, that sort of thing, but not specifically tied to anything religious, not even having sort of religious beliefs as a prerequisite.
And just to add to that, right, I mean, like scrupulosity is defined as seeing sin where there is none. So yeah, I mean, that could be within the context, like you guys are saying, in the context of religion, but also in the context of kind of just general moral, just morals. And just to add also, because I get this question sometimes, scrupulosity is not a diagnosis. It's kind of a metaphor for thinking about certain presentations of OCD. It's kind of a shorthand so that we kind of know what we're talking about. But as Jed and Reverend Katie were kind of saying, it can present in many, many different ways.
Mm-hmm.
Yeah, and lots of folks who are experiencing these symptoms that relate to religion might also be experiencing other themes as well. So I know I'll sometimes have folks that reach out and they say, well, I have the religious type of OCD, so I need that treatment. And it's the same treatment across the board. And that's what we're going to be talking about today with exposure and response prevention, that we're treating this in the same way that you would any other subset of OCD.
Mm-hmm. Also, if anyone has questions, feel free to pop them into the chat. I forgot to mention that. But when we're kind of talking about OCD, and particularly when Katie, you mentioned it's not leaning into your faith when you're doing these rituals and compulsions. Really, you're worshiping the OCD. But I would imagine that's sometimes difficult to parse out, both when you have scrupulosity with religious themes and scrupulosity with just more secular moral themes. So how do you go about kind of teasing out whether this is just like you're devout and you're practicing your religion, or this is OCD, or you're just a very moral person and you want to be empathetic versus this is OCD?
Yeah, this is something that's really difficult, but also really important. And this is a really great place that we're trying to get faith leaders actually more involved in this process to separate what is actual faith from what's OCD, because it looks different across faith traditions. It also looks different within faith traditions, depending on the sect or the denomination that someone might be a part of, or the way they interpret scripture, but then also on a very personal level. And the simplest way that I like to think about it is that there's kind of this spectrum, and something that you're doing because of your OCD is generally because you are experiencing fear, because you're experiencing obligation, because you are feeling like you need to be doing that particular thing, as opposed to doing something because it's a part of your faith. Generally, that's because it's bringing meaning, or it's bringing joy, it's bringing hope. And you can, by asking someone really what is the function of what you're engaging in, you can often get to, well, is this OCD, or is this something that's value driven for you? And sometimes folks get caught up in the fact that there are value driven reasons to pray when you're afraid. So I've gotten the question, well, what about when a plane is going down and somebody's praying because they're scared? That's not OCD. And I think the distinction there is they're praying because they're afraid. They're not afraid of not praying. And there kind of becomes this big piece of what is the function.
Mm-hmm. And Jed, as it kind of applies to more secular obsessions, like people can value being ethical and moral. So it seems to butt up or get confusing.
I think in general, I would say with OCD more broadly, you can sort of pull for these same sorts of questions. I mean, it's not unreasonable for people to hand wash. And there are situations where it's appropriate to hand wash a lot. I mean, if you're a surgeon about to go into surgery, you better be scrubbing up. And so you have to sort of calibrate all these things with attention to, as Reverend Katie is saying, sort of what motivates it, and what the drive is, what the subjective experience is. Is this something that, is you're doing misery and because you're terrified and that sort of thing? What benchmarking against other people in a similar situation. The same way where, if you were going to decide how much is a healthy amount to eat, you couldn't look at what Michael Phelps eats when he's training because it's a totally different sort of thing. So you have to calibrate toward the situation. So a plane going down is sort of a different thing from a lot of other situations. And then sort of functional impairment. So most people, at least in major religions, don't have this problem. And so the same things are somehow functional, right? There are Protestants who believe that you can sin in thought, and yet most Protestants aren't caught up with the obsessions. And there are Catholics who do confession, and they're not overusing it. And if anything, it's maybe you could imagine it as sort of acknowledging that, well, you're not supposed to sin, but you're human, so you're gonna, and here's a way to make things right, as opposed to OCD glomming onto it the way we know it can. Attention not just to motivational, although I think that's a huge part of it, but benchmarking against people in similar situations who share similar values, and just the actual impact in terms of impairment would be ways that you could probably answer some of those kinds of questions.
And it's a gray area, right? And I mean, that's one of the things that I sometimes run into clinically is that, folks who are struggling with this problem, they spend all their time trying to figure this out. Like, you know what I mean? Like, and maybe we can talk about like, what do we do about that? But it's like, how do I know? And then the OCD plays a dirty trick by telling them that, whatever they think, maybe it's the opposite. And there's so many different levels of the onion to kind of peel back. It gets really, and people, this is something that people really care about. In many cases, it's their their soul, right? For eternity. Where are they going to end up? And what does God think of them?
And these are all some of the reasons why this is such fertile ground, the inherent uncertainty of all of this, of the beliefs, of quantifying exactly what would mean what and how much, and you're supposed to try real hard or your best, but what counts. And those are things that other people who don't get stuck with the obsessions and maybe who don't have OCD, they can hear certain messages as more aspirational and not take them quite as literally, or they can take them literally, but understand that they're human and it's not going to be perfect. And you can't know 1,000% exactly wherever this line is, and you're acting in good faith and that sort of thing. But the inherent ambiguity of a lot of this stuff makes it fertile ground for OCD to latch onto if you do have OCD.
Yeah, that faith, and you kind of hit the nail on the head. The way I think about it a lot is like folks with scrupulosity, they've kind of lost faith in faith, right? Like I need to have a guarantee, and faith isn't enough. I can't just trust that God understands what I really feel and believe in my heart. I need to make sure in a way that's really not possible that God understands. And that's my understanding, is that that's not what religion is supposed to be about. That's not what faith is about.
No, it's really interesting. And that's why I always think actually engaging in ERP and trying to sit with uncertainty can actually strengthen faith for folks. And I've worked with a lot of clients that it's really interesting that they've moved through their treatment and they've really struggled with religion, and that they actually get back to a more value-driven version of faith than they've ever had, because faith is all about uncertainty. And it kind of makes faith, I don't want to say irrelevant, but it doesn't seem as significant if your faith is just about certainty. If you're saying, well, my faith means that I have certainty about God and certainty that my practices are this, that, and the other. No, the definition of faith is making the choice to believe in something that can't be seen, felt, experienced. So faith is really about that uncertainty. But I think the flip side, like y'all were talking about, is that a lot of people are in faith communities where sometimes religious leaders might not be defining faith publicly in that way. So sometimes even from the pulpit, we're hearing things about certainty, and other folks in the congregation might not latch onto that the same way that someone with OCD might, where they hear that and they're like, wait, so faith does mean certainty. So I tell a lot of folks that even as a minister, I don't have certainty about anything. Faith for me is not certainty. And folks like to argue with me and they say, well, my minister has certainty. They say they have certainty. And I always say, if they tell you that, they're lying, because nobody has certainty. That's what faith is.
Boy, it's wonderful to hear a reverend say that. That is just like, you should skywrite that.
Well, one way I sometimes think about that point, and it's not just with this type of OCD actually, is that the problem is sort of the threshold at which a person is willing to say they're sure. So this comes up a lot in my work, at least with patients who have sexual obsessions as well. And they're saying things to me like, but how do I know that if I were raised in a different society where it wasn't taboo and I hadn't been sort of taught this, maybe I would be attracted to kids and somehow I'm inherently a pedophile. And I think most people don't worry about that question. Like, I don't know, in some counterfactual hypothetical situation, like, I don't know, maybe I would be. Or about sexual orientation, when people are obsessing about whether they're gay, whether they're straight, and whatever particular fears are associated with that. But all these hypotheticals, when you ask most people about their sexual orientation, assuming they're not struggling and they have sort of figured that out or never had to struggle to figure it out, they just say they know. I'm straight, I'm gay, whatever it is. Well, how do you know for sure? Like, the question doesn't make sense. Well, but if you were in jail or you were in this situation, maybe with, right, yeah, right, maybe. I don't know that for sure, but I still call that being certain. And so it's true also of faith and of religious practice, even if it's not about belief, but it's actually about the way you do the religious ritual and that sort of thing.
Well, I mean, like when I was going through treatment, I remember the whole thing was just being able to accept uncertainty and be able to sit with it. But I think one thing that's different about treating scrupulosity than I had contamination OCD, so it was very much like this is terrible. I just want to my treatment mentality was very aggressive and just beat the OCD out of my head completely. But I feel like if you're a clinician dealing with someone who does want to be faithful afterwards and wants to keep their morals after treatment, I feel like it could get tricky, crafting exposures and stuff like that allow you to engage with faith while also fighting your OCD. And I know those two aren't incompatible because you can get treated. So how do you navigate that kind of complexity?
Yeah, that's a lot of the work that I'm starting to do is working alongside clinicians who are engaging in ERP with clients and helping the client and the clinician figure out how can that person live into their individual faith tradition in a value-driven way, not in a way that's driven by the OCD. And that's been a journey and a process and something I'm working on and doing research around right now. But I think right now, the things that I've seen just anecdotally is that, again, someone can get back to their faith in a value-driven way, maybe for the first time. And I always tell them it seems like ERP is opposing your faith, but it's not. It's opposing the OCD. You're really breaking down the OCD so that you can figure out what you actually believe and enjoy that faith tradition for the first time. I think that's often why ACT and things like that go really, really well with this component. And for folks on here who might be listening who work on the spiritual side, there's a lot of research on the way that acceptance and commitment therapy overlaps with the work of interfaith chaplaincy. And there's actually some research on the crossover where faith leaders can actually help folks move towards their religious values while they're engaging in ERP. But just as a note, I think there's a lot of fear in that. And like Kyle said, it does seem contradictory to say, well, you have to do these things that seem to maybe oppose or against what you believe in your faith tradition. And again, that's not what we're asking. It's to be uncomfortable so you can get back to your faith. And I often tell folks, God can handle your exposures. If God can handle all of these big things that are happening in the world, God can handle these small exposures that you're doing in your life so that you can get back to that value-driven life that you were created by God to live.
Yeah, and I guess I'd also be really curious to hear Jed and John. So you're where as a clinician do you start? What do exposures look like for this kind of stuff?
I mean, as always, it's going to be so different person to person in terms of specific things. But first off, I totally agree with Reverend Katie. One place to start is framing treatment in service of a person's values. So most people with scrupulosity, we even have data that show this if you needed convincing, find that it actually interferes with their either religious experience, relationship with God, however they think about that. And so you're trying to help them violate the OCD so you can cut the OCD out and they can live whatever kind of life they want to live. I think you should never be actually violating proscriptions. It's perfectly fine, and there are people who struggle with religion, are resentful of religion, have problems with religion and don't feel good about it, and maybe they choose to reject it and maybe they choose not to. But if they're staying within the religious tradition and they have a problem with that, that's not OCD. That's not going beyond. That's just religious conflict and struggles, which is perfectly fair game for people. The problem is, like, again, when people are being excessive or overly something. And so I think that for several reasons, you don't want to be violating things that are actually violations of somebody's values, beliefs, system, and that sort of thing. You wouldn't do it in any other area. So if you, the example that always comes to me, and some of you have probably heard me say before, is if you were having obsessions about possibly accidentally stepping on, say, a contaminated needle, and getting AIDS, HIV, hepatitis, whatever. And so you always wore steel-toed, reinforced boots everywhere you went, and you wouldn't go outside wearing sandals or maybe even soft sneakers. So what would you do? Would you say, well, we need to practice tolerating uncertainty? You can never be sure, so let's go find some dirty needles or some random needles and stick them. That's of course not. That's the thing that the fear is of. What would you do? You'd practice taking risks that other people see as acceptable risks to take. Maybe you'd push the limit and go kind of far. So you'd certainly go around wearing sandals, maybe flip-flops. Maybe you'd even walk around the block barefoot and even not looking down so carefully. Some people would do that, or certainly would do that. And you'd pay attention to the fact that what's on the line here is maybe I'm going to accidentally step on something that's contaminated and I'll get this awful thing. But sort of there's just a human consensus in that sort of situation that's that would be terrible. That's a risk we could take, right? So the same thing within religion. If somebody keeps kosher, you don't say, let's go eat a cheeseburger. That's just violating the rule. And even if they get a special dispensation, oh, you're sick, so do it. But now they're not practicing sitting with uncertainty. You've basically built in a compulsion. They don't know how to disentangle their religious from their obsessional sort of fears and concerns. And so that it doesn't even help in that case. What you would do is do things that are permissible, either that other people without OCD would do, or sometimes, again, pushing the limit and doing things that are not violations, even if they go kind of far, with attention to the potential risk, but without crossing that line. Because again, what you want, Kyle, you said it, you want people to be able to get okay with sitting with uncertainty, with living a normal, healthy life. That's what everybody's been saying, that is not way out of whack with what other people are doing, that is motivated not by anxiety and fear reduction. And so that requires actually staying within the bounds of what is technically acceptable to that person within their moral or value sort of system.
Sitting with uncertainty and operating with uncertainty. When clients say, you mean I have to just sit with my uncertainty? It's like, no, you got to act with it. You got to do your stuff and be involved in your life with the uncertainty. And I love what Jed and Reverend Katie are saying. I would just add that, whether you have scrupulosity or not, we're all in the same boat. I see someone, John wrote, my biggest fear is going to hell. And we're all in the same boat as far as like, no one knows for sure if they're going to heaven or hell. Again, it's great to see Katie, agreeing with this, because I tell this to my patients all the time, but I'm kind of like, I'm not a reverend. I don't know, no one knows. I don't care what religion you are. No one knows for sure if there even is a heaven or hell, or for that matter, and this may sound blasphemous, but it's not. No one knows for sure if there's a God. People have beliefs, people have faith, but lots of people don't, or they believe in different gods or stuff like that. So we're all in the same boat. And I think, Jed, you were kind of saying before, the problem with scrupulosity is that folks who have that problem, they're not able to kind of move forward, not having that. They're not okay with the faith. They've got to have an ironclad guarantee. And what we want to do with exposure therapy is help people to be better at faith, better at uncertainty, I think.
I absolutely. And everything you just said, the sitting with it piece for me, I always talk about with values, like even going back to the ultra piece, my motto is running towards your values, or running towards my values. Cause I think it's about continuing to be in movement towards those things that are important to you in the midst of that uncertainty. And because you're uncertain, it doesn't mean, again, that you can't have faith. So folks who are listening to this, when I throw my hands up, it doesn't mean I'm like, God, who knows? It means I have radical faith that there is, but I can accept the uncertainty that I'm never going to know for sure, because that's a part of life, but continue to live my life with radical faith, the same way that we would have radical faith that this treatment is going to work, or have radical faith that this is really OCD, all of those other aspects. And then going back also to what Jed was saying, it's so important not to violate someone's faith tradition. And as folks are getting into ERP, please know that when you're working with a clinician, that is not their goal at all. And I think a lot of times what folks are trying to determine is what's discomfort versus what's disrespect. So we want you to be uncomfortable as you're going through treatment. That's kind of the point. So you can sit with uncertainty, but we're not wanting to cross that thin line into disrespect. So I always think, someone isn't going to want to do an exposure no matter what, most likely, because it's something that's uncomfortable. But asking them the reason with faith traditions that they don't want to do it can be really helpful. So if you say, well, why don't you want to do the exposure? And the answer is, well, what if the divine gets upset at me? Or what if something bad happens because of it? Probably OCD. But if their immediate response is, how could I possibly reconcile doing things that nobody else in my faith community would do? That's probably something disrespectful that we shouldn't be asking them to engage in if 80% of folks in that tradition wouldn't do it either.
So when you're conceptualizing exposures as a clinician, like it's still a little bit hazy to me. How do you go about like making an exposure so that you toe the line to get them uncomfortable but not be disrespectful?
I think you want to find situations that, I'm just kind of thinking out loud here, that for the person, they perceive that it might be, well, let me backtrack. The purpose of exposure is to learn new information. And for folks who have scrupulosity, for the most part, what we want them to learn is that they can do uncertainty, they can do faith, that they can manage without having to get a guarantee, even in a situation where that uncertainty is like right there in their face. And usually what that's going to map onto is doing things that maybe they perceive as being sinful or crossing a line, but that, realistically and according to tradition wouldn't be. I don't know. I'm trying that out. Let's see what Jed and Reverend Katie think.
I have sort of two thoughts. One is that disrespect. So it kind of depends to me whether we're actually violating a religious prohibition. And so, if violating a religious prohibition, might be in the category of disrespect, although I actually would just conceptualize it as off limits inherently because it's violating the person's system, not because it's disrespectful per se. And once it's not violating, to me, I think a lot of what disrespect hinges on is the framing and purpose. So if you're trying to cut OCD out, which is wrecking the person's religious experience in order to have an authentic religious experience, it seems to me inherently not disrespectful. Now, somebody might still say that behavior crosses a line that I'm either not willing or not allowed to cross. I mean, first of all, anybody with any kind of OCD can always say, I'm not willing to go that far. People have autonomy, and it's hard to imagine that you can't be creative and find another way, if it's really scrupulosity, to violate the OCD without violating the religion. So to me, I don't. And the caveat here is I work most often with people, with Jews who have scrupulosity. And with Judaism, this is a little easier because it's very sort of like, where's the legalistic boundary kind of thing, as opposed to violating some slightly more amorphous thing, offending God in a more generic sense. So it might be tricky applying this across the board, but I'm not often feeling like I'm stuck about being disrespectful. It's about finding a way to not do something that's prohibited, but do something that's uncomfortable in service of you having more of what you're shooting for in terms of the values. So to me, again, that's inherently not disrespectful. It doesn't mean the person will always say, yes, I'm willing to do it. Mm-hmm. But it's not disrespectful to help somebody actually have a more a better experience vis-a-vis those very same values. If I could just tack on one last thing, I know I'm talking a lot, but I just want to say that uncertainty, in terms of uncertainty and having faith that we were all talking about a few moments ago, not all doubts are 50-50. And I know that sounds maybe obvious, but I think people caught in the obsession experience it as, if it's possible, then it's sort of like a toss-up. Clinically, I've noticed that a lot. I've had a lot of conversations with people who say, the chances of something that's really, really improbable, it's like 50-50, 50-50. Like, what do you mean? Well, it could happen or not. But of course, everybody understands you could win the Powerball or not. It doesn't mean you have a 50% chance of winning it. And so we're never asking people, I can't think of any case with an OCD exposure where we're trying to have somebody take 50-50 risks of their core fears, scrupulous or not. Again, back to the dirty needle kind of example. We're not like, well, 50% chance, you can't be sure, let's go for it. So we still want people to learn how to make moral judgments and how they think through the morality of that sort of thought. And even if it's immoral, well, what are you supposed to do about that? Because it's not so easy to control your thoughts. And okay, you shouldn't think that. What happened? What does your priest do when your priest thinks that kind of thing and that sort of thing? And so we're having people clarify their beliefs, values as well, judgments about these things, and then tolerating the uncertainty that they can't be 100% sure. As John was saying before, people want to know 100%, but it's not like, well, Reverend Katie referred to sort of radical faith, and I understand what she means, but I'm just clarifying that's not like I have no idea what I think, but I'm just going to guess. It's committing to what you want to commit to, which includes thinking through what you believe and what matters to you, and tolerating not knowing it 100%.
And I love the 50-50 piece you brought up too, because I think that's so often speaking as somebody with OCD, whenever I was asked to sit with uncertainty, I thought I was being asked to sit with this kind of 50-50 scenario. So most of my OCD related to kind of harm related stuff, where I felt like a complete fraud in ministry because of these intrusive thoughts. And in ERP, it was, well, yeah, I may or may not be this horrible, dangerous, murderous person. And the 50-50 for me, that's what it felt like. Seemed like, how could I possibly imagine that? How could I possibly sit with that? What does that mean about me as clergy? What does that mean about me as somebody who works with kids? All kinds of things. And it was a really big shift, not even just about religion, but for me with this, in that faith component, like Jed's talking about, it's not this 50-50 thing. There was also this element of accepting uncertainty while still believing in myself and believing in my treatment and believing in my diagnosis, and still moving forward, not knowing for sure. And that's what we're talking about with faith too, that you can have really strong belief in your Christian tradition or in your Jewish tradition, your Muslim tradition, in Hinduism, whatever that looks like for you. And we can still say, well, we're never going to know for certain, but we're choosing to move forward with strong belief in this direction.
John, I was going to ask a question from the chat, but before I get to that, do you have any questions as a clinician and someone who's, has the opportunity to ask a question to two people who know a lot about this topic?
I don't know. I mean, I feel like we're all on the same page so far.
All right.
Yeah.
I'm sorry, I'm going to butcher this. Chatanya at 1224 asked what to do about such obsessions which arise about genuine safety issues, which are true, but obsessions make a mess to look after that genuine issue. So we touched on this before, but I just wanted to hear your guys' thoughts on this question. And it seems to me just like, what do you do about an obsession/compulsion when, there's actually a threat that other people may respond to, kind of like COVID, I guess, in a way, like.
My intuition is that we would need to know a lot more about what that means exactly, that there's a genuine safety issue, right? There's the obsessional version of that, which is pointing out that there's always, in a literal sense, possible safety issues. But people have to live lives accepting some of those risks, and we all sort of agree to. And then there are ones where just because somebody has OCD doesn't mean everything they're worried about is part of that. Right? I find this a lot. Somebody's doing a lot better, let's say, or somebody with social anxiety is doing a lot better in treatment, and then they have like a really important job interview, and they're really nervous, and they're like, well, I'm relapsing. You're not relapsing. That's a situation where it's appropriate to feel that sort of way. And so COVID that you mentioned is a good example of that. The things that we were used to doing a lot and were safe to do, and we were able to use in treatment for exposures and really push the limit, some of those things became unsafe to do at various times during COVID. And so you wouldn't do them just because they would also be an exposure.
An earlier question too, just getting back to kind of like broadly characterizing scrupulosity, asked about, I think, religious scrupulosity, and they asked, do compulsions have to be religion related? And I guess kind of off that, like, what are some compulsions maybe to look for in both moral scrupulosity and religious scrupulosity that may help clinicians and people who may think they have OCD kind of get a better sense and handle on what's going on in their head? And I know it's going to be different for everyone, but in a general sense.
Yeah.
Well, go ahead.
Go ahead. No, go ahead.
I was gonna say praying is like a big one. Confessing, asking for reassurance, repeating rituals. I think, as Jed pointed out, different religions emphasize different aspects of, religious practice, right? So for some, it's praying and confession. In others, it's more doing rituals, making sure the rituals are done perfectly, just right.
Mm-hmm.
But go ahead.
No, and you hit on most of it. I was going to talk about just any excessive display of devotion, and that might be reassurance seeking from a religious text, or maybe avoidance of a religious text as well. It could go either way. For some traditions, this will be really focused on kind of excessive cleansing or purity rituals. It can look really different across the board, but like you're saying, anything that's excessive in terms of prayer, religious ritual, cleansing, or maybe avoidance of those things as well could be seen as a compulsion for Scroop. And Jed, I'd be curious your thoughts, but I've definitely seen folks who have obsessions around religion who are doing compulsions that aren't quote unquote religious. Like I think the comment in the chat was tapping. And I've worked with folks who feel like I need to touch things in a particular way before I leave my house, or my entire family is going to go to hell. Or there's sometimes, I'd be curious if there's a specific name for this, but I have seen folks that almost have kind of this spiritual contamination piece, that it feels like something is spiritually contaminated that has something that it does not relate at all to religion. So worked with someone who the word compassion was spiritually contaminated. So they were worried that anytime they heard the word compassion, their entire family was going to be doomed by God.
Yeah, I would also just, connect this back to some of the things that were said earlier in the hour. This is OCD, and the category that we're calling scrupulosity, it's an artificial construct, right? It's useful for us to think about that way. It's not different in some very fundamental sense. It's a challenge in certain ways that can be harder for both people with it as well as clinicians sometimes to work with, for various reasons that we've been talking about. But it's not like a real thing. And the reason I'm saying that is trying to figure out exactly where the line is between scrupulosity and not, and what if the compulsion that's related to the religious or moral obsessional core fear, what if the compulsion itself isn't a religious behavior per se? Right, OCD is very creative. You might want to prevent harm to a loved one by tapping, and right, yeah, okay. That's all fair. And it's really hard to actually draw a clear line, because, for example, what about just aggressive harm obsessions? So like if I'm having obsessions that I'm going to kill somebody, is that scrupulous? Because it's sort of widely accepted across cultures that if you just kill somebody for no reason, that would be a moral violation. I would say we probably don't call that scroop unless the more explicit fear, or the fear takes the form more explicitly of, and then I'd be a bad person, or something moral or religious. But just because the fear is about something that is immoral doesn't automatically make it scrupulous. And so it's same on the compulsion side. It's really all OCD, and OCD is as clever as all the people who have it are, and can come up with very inventive ways to scare the hell out of you. No pun semi-intended. And similarly with the compulsion. So sure, the compulsions can look like anything.
And just to add to that, I mean, OCD isn't like a thing that gets inserted into your head. OCD is coming from the person, and people with OCD are smart, and sometimes that intelligence gets in their way, and they realize, hey, there are no guarantees. I actually don't, I don't know if I'm going to hell. Oh no, now what? And they're smart enough to realize that, Not that other people who don't have OCD aren't smart, but they tend to focus and then, they perceive it as the saber-toothed tiger that they don't know for sure. But yeah, I think that's a great point.
Yeah, I mean, I would just say OCD is OCD is OCD, and the reason we talk about it in these categories is really to help people know about and find treatment to recognize that they have OCD, not because it's a different type of OCD than anything else. And just like anything else that we're talking about with OCD, it's really latching on to the things that are the most significant to you. So it's not necessarily that everybody who's religious, they're going to have OCD around X. It's just happens to be people who have OCD who are in faith communities. That's important to them, so their OCD is going to latch on to that. I'm thinking about we've talked a lot about Abrahamic traditions, but if we go outside of that, I'm sure we have folks who are listening on here who might have obsessions around Hinduism. So some big things that we might see there are somebody worrying that they don't pronounce the shlokas correctly, or worrying that they're going to not have appropriate progress in Dharma, something like that. And this isn't some separate category of OCD. It's just that they've grown up in their temple hearing about these concepts that are so incredibly significant to them. And their brain has latched onto that the same way that a mother whose child is significant to her, their brain might latch onto that.
One other thing, if I could throw it out there, is I find in general, again, not specific only to script, but here too, that OCD will, one way OCD is opportunistic is by trying to to anthropomorphize, trying to scare you by pointing out other things that might sort of be a proof of concept. Like, but you actually did that thing, and so maybe that means. And so, that can be really about anything. But when people were asking about, what about if it's somewhat true? And what about if there's a real fear? OCD will like to do that. If there is something that you did that violated actual religious rules, to take that example, or if there was a time where you had a sexual thought, maybe actually was more of a fantasy and enjoyable, but a little more taboo, at least in your belief system. So OCD people will be like, see that shows it. I'm thinking of somebody I worked with who, growing up, had a lot of, was raised very religious, and as a teenager started to have sexual thoughts about, this was a man, about other men. And at first was like, no, like that can't be, that would be bad, and sort of dismissed it, and came to understand about himself over the years that he was probably gay. And what his OCD then did was start to scare him that he was a pedophile. And the proof of concept was, but the thing you thought was immoral when you were younger about your sexual interests turned out to really be true about you. And that's going to happen here too. Now you're having the thought, no, that's immoral, I don't really want it, it's just intrusive. But when you have those kinds of thoughts about sexuality, sometimes it turns out that that's really what you like and what you want. It's going to turn out that way here too. So that can happen with religious stuff, with moral stuff, really with, again, all kinds of OCD.
Mm-hmm. And another kind of question more aimed at clinicians is particularly aimed at Katie. So get ready. But I guess another challenge presented by treating someone with scrupulosity, particularly religious scrupulosity, is it seems like you need to know a little bit about their faith tradition and what would constitute butting up against a real rule in their faith community. So what would you suggest clinicians do kind of when working with a client with religious scrupulosity, and when, if ever, do you get a member of the clergy involved?
Yeah, this is such a great question, because it does look so different kind of across the board. And even listening to Jed talk kind of from the Orthodox Jewish perspective, I was writing down kind of his thoughts on the disrespect versus discomfort, because it looks so different when I talk to folks who might be Protestant or who might be from a Hindu tradition where it's more free flowing and the language is very different. So conversations, obviously, like the ones we're having today, are super, super important. But I think pulling someone, pulling a clergy person, pulling a religious leader or faith leader from that person's tradition can be really, really helpful for a clinician to be able to separate, well, what is actually their OCD from what is their faith? What are exposures that aren't crossing that line, whatever it is we're calling that line, whether that's rules around the faith or whether that is something that's disrespectful within a particular tradition. And I think the tough part about about this can be a lot of faith leaders don't know a ton about OCD, right? So sometimes for those faith leaders, it might look like, well, that person is just doing something to really live out their faith, or they're just really doing that in a way that means they're incredibly faithful, right? So one of the things I know we're trying to do with the IOCDF is raise awareness around that. Jed and I have been working on an IOCDF Faith and OCD task force, where we just had a big conference last week where we had a lot of sessions geared towards faith leaders to talk about that. We have a new website that I know Skyla's been posting that just came out with resources for faith leaders. Because I think if faith leaders do understand, and I really do think that for the most part, they would want to understand what OCD is, what religious scrupulosity looks like, they can be really great partners in this. So that's some of the work, Kyle, to your point that I'm doing. I'm kind of going into full time of playing the faith leader side with clinicians because of my interfaith background and working with a lot of different faith traditions. But long term, my goal is to be able to train lots of clergy from lots of faith backgrounds and have something that's kind of ethically based out of the IOCDF, so that different clergy can essentially have a stamp that says, well, we understand religious group and we can work alongside and consult in these particular cases. Because if they know OCD, it can be really helpful with all of the gray area that we're talking about. That was a much longer answer, I think, than you needed. So sorry.
That's great, though. Very much needed.
Yeah,
I'll just say, for me, I find that most folks have already spoken with clergy and they know what the answer to their questions are going to be. And if I say, if a person says, if we're suggesting exposures, well, maybe we should do this. Well, let me just check, let me make sure that's okay with my priest, rabbi, whatever, reverend. And if I ask them, well, have you talked to them about this before? Yes. Okay. Well, so what did they say in the past? Well, they've always told me that it's okay to do this, because it's OCD treatment. What do you think they're going to say this time? Yeah, I think they'll tell me the same thing. So do we really need to go? And helping them to start to kind of think independently for themselves, because then it just becomes reassurance seeking. They already know what the answer is going to be. So and they'll say, yeah, but I'm not sure what they're going to say this time. Exactly, that's the point.
More uncertainty.
Right. We want to be better at being able to be independent about these things. Not everyone goes to their religious authority when they have any question. They work it out independently.
I actually think that what John is saying here is even more than just helpful in terms of strategically getting people to go. But I see that, at least for some people, as a core thing that the patient needs to learn in treatment. In other words, you have to learn how to make judgments about what's a legitimate question that needs consultation or you need to look up, and what's an obsessional doubt where you basically know the answer, as in those examples that John just gave. You basically know, but you're sort of trying to get reassurance, or you can imagine there could be an exception, and those are not the same thing. And for somebody with scrupulosity, they may see those all as the same. I don't know for sure, so I don't know. And it's important in treatment to get better at making the decisions about the things that are actual uncertainties in a literal sense, in the sense of I don't know and I need to find out, and those things that are uncertainties in the I know 99% or even 95%, and that sort of thing.
And the reassurance piece you bring up reminds me of this other component too, which is the flip side, not necessarily the pulling clergy into treatment side, but the fact that a lot of times clergy are on the front lines for individuals who might be navigating OCD and who might be navigating specifically this kind of religious subtype. And one of the things that I think is becoming really important that we're working towards is trying to educate clergy, not just so that they can help with these cases, but so that if someone is coming and asking them over and over again for reassurance around if something is moral or ethical within the faith tradition, that they can recognize, this might be OCD. This might be something that I should refer to a local OCD specialist for this person to work with them. So that's really something that we're trying to move towards too, where faith leaders have enough knowledge to say, okay, this isn't just reassurance seeking because someone has a question about their faith. It's repetitive enough that there's probably a diagnosis of OCD here.
And since this is the Research Roundtable, do you guys have any or general sense of how churches or wherever you practice your faith, how they tend to respond when people are going through this treatment, and how members of the clergy tend to respond to people doing exposures that, may seem on face like they're not performing their faith rituals maybe as strongly as they were before.
My experience has been overwhelmingly positive. There's one exception I can think of over all these years where the clergy member was maybe encouraging the problem rather than the solution. I think a lot of it has to do with the approach you take. And so, obviously you and the clergy member are sharing different kinds of expertise in service of helping this person. And there, some clergy and some people who come for treatment even may be understandably nervous or skeptical. Psychology has a history of pathologizing religion. That's not made up by some people. And so helping people understand this is messing with the person's religious experience. And we want to cut that out. And so, for example, I'm often, at least with, again, the Jewish folks with Scroop, I'm often trying to find ways to see how far we can go, how close we can get to violating a religious prohibition without crossing the technical line. So I'm collaborating with clergy. I may want to get some help on that, whether it's signing off on certain approaches or even saying, like, we're not sure how far we can go. Can you help us? But you can imagine that's a weird paradigm shift for clergy. Like, most clergy are not being trained to see how much you can get away with without technically crossing the line. So you need to help them understand why you're doing it. We're not trying to get rid of the religion. That's not why we're trying to go so far. We're trying to violate OCD without violating religion, and by still being, if we're going to call that respectful, we can call it respectful of that line. Help us get there so that we don't actually encourage something that would be a violation, but we can get rid of this OCD so the person can otherwise have the life that they want.
Yeah, I love that perspective. I end up seeing it from a different side with the clergy piece. I've spent the last 7 years working with kids from different faith traditions. So this isn't just from the OCD perspective, but from the mental health conversation perspective in general. And it's been, I think, a mixed bag. I've had some really, really supportive clergy from different faith traditions. I've had some that don't necessarily fully understand this mental health component. And I don't think it's from a place of wanting to do harm. It's just a place where there's a lack of awareness. So I've worked with a lot of kids through a lot of mental health concerns that sometimes clergy feel like, well, if you just prayed harder, or if you just did this, or if you just did this thing, it would go away. And that's not the case. But I think that's where education comes. And to Jed's point, most of the time where I've been able to actually sit down and have a conversation and explain and have this open dialogue and not come at it from this perspective of, well, I know this and you don't, then usually that conversation is able to unfold in a positive way. Because I do think there tends to be a distrust on both sides. Often clergy distrust folks that are kind of in the psychology world. And then I think the flip side as well, because often clinicians see faith leaders who might be saying things like, well, if you just prayed harder, well, if you were just more faithful. But both are really significant in this process. And Jed, I love that you said, because I don't hear this all the time, that clergy have this really specific expertise too. And I think by bringing together the expertise of both clinicians and faith leaders in this process, we can really get folks back to a place where they can engage with faith in a healthy way. I know we're out of time, but I just also want to acknowledge, because this has come up a lot recently, that there are some different scenarios for folks who have experienced religious trauma. And that's coming up as an area for a lot of folks I work with as well, where they might have experienced some form of religious trauma within a faith community with a particular faith leader that's then impacting that treatment as well. And that's a whole different component than what we're talking about, but something that's also very real.
Mm-hmm. John, do you have anything to add real quick?
What's a religious, how would you define a religious trauma?
Yeah. Oh, that's longer than that's a very long answer. Okay. So there's actually a whole movement around identifying religious trauma right now. And there's a really cool institute called the Religious Trauma Institute that's training both clinicians and faith leaders around this. And this can obviously be things that are incredibly physical, where someone could experience sexual abuse or something like that within a faith community.
Okay.
But that also could be, there's a really big movement right now of deconstruction from particular faith beliefs, where someone has spent their entire life in a faith community where there's been a religious leader in a position of power who has maybe said things that have made them feel belittled, or who have made them feel very uncomfortable, who have made them have a particular view of the world that has completely turned their worldview upside down, where they're now experiencing what someone might be experiencing from an abusive relationship. So I end up seeing actually a lot of folks along that is a lot of the stuff that I do, where a clinician will recommend that someone talk to me because someone has no healthy relationship with faith, because they've been a part of a new religious movement, or they've been a part of a cult or a religious trauma situation where they've spent 10 years with OCD in this environment and now want to get back to their faith tradition while navigating ERP. And there's all these different layers on top of the OCD to kind of unravel.
That's cool. I've never heard that.
Yeah, me neither.
Yeah, interesting.
Ending on a very positive note as well.
Sorry. Yeah, sorry. That took a turn.
I asked the question, sorry.
Well, we are out of time, but I want to first thank our panelists for being here. Thank you for taking the time and providing all your knowledge. There are some announcements I want to make really quickly. First, the annual IOCDF Research Symposium registration is open for it. It's in July. It's a hybrid in-person online event, and you can learn more and register at iocdf.org/symposium. Also, registration is open for the 27th annual OCD conference taking place in Denver this July. The special event is for the entire OCD and related disorders community, including individuals, family members and supporters, therapists, and researchers. Learn more and register at iocdf.org/OCDcon.
Come meet us in person in Denver. Who's going?
Yeah.
You guys are going?
I'll be there.
Awesome.
Jed and I we're presenting, I think, at least one thing together on
Oh,
faith.
nice.
That's right. I think that's right.
Yeah.
Yeah, John, I still haven't seen your legs. Like, you may not have them.
I don't have legs. I'm
I'm going to have to deal with the
That
uncertainty.
might not be the nicest thing to say, because there might be people who don't have legs. But
But he also can't show us because he might not be wearing pants.
is
ooh, how did you know, Jed? We're still live.
All right. Thanks, everyone.
This was fun, guys.
Thank you.
Thank you, guys.